warm welcome to today's International Faculty Webinar. And it is my great honor and pleasure to have a very distinguished faculty, Professor Djillali Anansar. Sir, you know, it's synonymous with the use of steroids in septic shock and other conditions in the ICU. He has done remarkable work on steroids in the ICU, and I'm sure all of you are aware of his work and his famous trials. So just to introduce him, apart from the work that he has done on septic shock and steroids in other conditions also, Sir is Raymond Apollinaire Hospital Professor and University of Paris-Saclay, Carchis, France. And he's also the Gonchi Professor of Shanghai Ruin Hospital, Shanghai Jiatong University School of Medicine. Sorry, sir, for the pronunciations, but Chinese, French, and all, it gets very difficult.
Don't worry, it was perfect.
So with that, sir, I hand it over to you to teach us about steroids.
Thank you so much. It's a great pleasure to share with you this afternoon some thoughts and data about the use of corticosteroids in patients with sepsis. So here you can see my declaration of interest, and I must say that as I spent almost whole of my career working on that topic, my main declaration of interest is of academic, obviously. And so, as you should understand, I have a positive view of the use of corticosteroids in patients with sepsis, and I will explain to you why. Let's start with some pharmacological considerations. So this is a very important review paper you need to look at, published 2 years ago at the time of the 75th anniversary of corticosteroids. This is illustrating from the mid of the 20th century, at the time of the discovery of cortisone, all important steps over the time up to now. And the blue boxes here are highlighting major discoveries in the function of the glucocorticoid receptor. And the purple boxes are highlighting major and disruptive innovation in molecular biology. And one can see how new molecular biology resulted in new understandings of the role of the glucocorticoid receptor. And think about it. Only 2 years ago, a major advancement in the understanding of the role of glucocorticosteroids in modulating inflammation came from the discovery of the role of the role of a glucocorticoid in the metabolism of the immune cells, and I will come back to this. So that is a very important paper to read for you if you're interested to know about what we know about corticosteroids and how things have evolved over time. Okay, let me, looks like I have, sorry, technical issue moving my slides. Yeah, so this is also an important message about understanding the role of the glucocorticoid receptors. There are many forms of the glucocorticoid receptors. The two mains are the monomer form and the dimer form. So the monomer form is known to be mainly involved in development, in cell phase, in tethering, and also is associated with many side effects around osteoporosis, for example. The dimer is more involved in the cellular processes and in anti-inflammatory gene induction. And also in terms of side effects from glucocorticoids, it may be the driver of metabolic consequences like hyperglycemia, for example. So there are new agonists that specifically bind to the monomer form or to the dimer form. And depending on which form is involved by an agonist, you get different effects of glucocorticoids. On top of that, there are a number of other factors, cofactors, issues related to the concentration of the ligand, the role of the environment in the tissue, the pH, and also epigenetic phenomenon. All of these additional factors will modulate the function of a glucocorticoid receptor, whether it is the monomeric form or the dimeric form. Very importantly, we know that the glucocorticoid complex formation is required for surviving sepsis. So that process, that molecular process, is a condition sine qua non to survive a stress like sepsis. And one can see, for example, the different effect of the monomeric or the dimeric form in that specific context. So one can see that the dimeric form here is going to inhibit the pro-inflammatory cascades, for example, IL-1 beta, ISG here, is also promoting other signaling pathways that will promote phagocytosis from the immune cells. And the monomeric form, as one can see, is, for example, inhibiting the TNF-alpha pathway. On the other side, one can see that the dimeric isoform is also involved in the metabolism process, will interfere with the production of lactate, with glucose production and delivery, and also involved in the cardiovascular homeostasis. Among recent discoveries about the function of a glucocorticoid is the understanding that the dimerization process is of utmost importance in the modulation of inflammation. And any abnormality in the binding of a GR at the DNA binding sites may result in an abnormal dimerization process, resulting in the loss of a glucocorticoid receptor mediated function. So this is the optimal situation where the complex is going to bind adequately to the glucocorticoid receptor element. And when that binding occurs, a cascade of events will succeed in achieving the dimerization process in a very stable manner. By contrast, in this case, one can see that the binding is suboptimal, and thereafter, the subsequent cascade is disrupted, preventing the stabilization of the dimer isoform, and the function is going to be lost. So also glucocorticoid receptor activation is preceded by metabolism, by intracellular metabolism pathways, and that occurred in the kidney, in the liver, but also during inflammation in other tissues like the adipose tissue, for example. And that main metabolic action is the shuttle that inhibit cortisol to the inactive cortisone form. So one can see that the first step in the cell the pre-receptor metabolism of glucocorticoid is essential to the subsequent activation of a glucocorticoid receptor. So either the 11 beta hydroxysteroid dehydrogenase 1 is present and then is activating toward active cortisol and promoting the signaling of a glucocorticoid receptor, or it is the type 2 isoform that is predominant, and then it will inactive cortisone and prevent the glucocorticoid receptor signaling and pathway. So another pharmacological element that is important to have in mind to understand how corticosteroids may be helpful during sepsis and acute inflammation is related to the duration of the treatment, of treatment effect, actually. And that is really dependent of a chemical structure. And so the HO here component is a major factor influencing the duration of action. So it is associated with short acting. So, and the CH2 component here is, by contrast, associated with increased half-life of the drug. So that is very important, again, when using corticosteroids in the context of acute inflammation and sepsis, to understand that the different type of molecule will have different duration of effects. Another level of complexity, but finally easy to understand, is that glucocorticoids have genomic effect mediated by the glucocorticoid receptor, and they also have non-genomic effects. And so when looking specifically at trying to discriminate between genomic and non-genomic effects, one can see that there are two important factors. So the reference molecule here is hydrocortisone. So everything is compared to hydrocortisone. And one can see that, for example, here in the black box here, dexamethasone has a 25-fold higher genomic effects than hydrocortisone, the same for betamethasone. And when one looks at the non-genomic effects, one can see that betamethasone has almost no non-genomic effect as compared to dexamethasone or even to methylprednisolone. So very important to know that also betamethasone and dexamethasone are equivalent in terms of glucocorticoid activity. Betamethasone has almost no non-genomic effects. Now, when looking at the role of the dose, how the dose influence genomic versus non-genomic effects. So here one can see different dose from low dose, medium, high, very high, and pulse therapy. So that is a global effect of corticosteroids. So very unsurprisingly, the higher the dose, one can see the higher the anti-inflammatory effects. Now, when discriminating non-genomic effects and genomic effects, one can see that the genomic effects, those that are mediated by the glucocorticoid dimer form, actually achieve a plateau very rapidly, around, you see, 30 to 50 milligrams of prednisone equivalent. And then you can further increase the dose, you get no more additional genomic effects. By contrast, the non-genomic effects in the dotted line here, one can see that you have almost no non-genomic effect with those lower than 40 milligrams of prednisone equivalent. And then you have a sharp increase proportional to the increase of a dose. And one can see that approximately around 150 milligram prednisone equivalent, very high dose, then most of additional effects are non-genomic effects. So when, for example, one use pulse therapy as compared to a high dose of corticosteroids, the main difference is to getting more non-genomic effect, is not to getting more genomic effect or GR-mediated effect. When I was at the medical school, I was taught that glucocorticoids are immune suppressive drugs. In reality, is not the case. And this very nice work by Bornstein in Germany, 20 years ago now, what he did with his team, he took monocytes from healthy people and exposed them to dexamethasone ex vivo, and it looks at what are the genes that are expressed or downregulated. And what he figured out is that there were many more genes that were upregulated than genes that were downregulated. So highlighting that the monocyte function is not suppressed, it is reprogrammed. Sorry for that. It is reprogrammed. So basically, in particular, one can see that the cluster of genes that are involved in innate immunity or innate either inflammation and innate recognition are upregulated. And genes that are involved in adaptive recognition and adaptive immunity are more likely to be downregulated. So the take-home message here is when a patient is exposed to dexamethasone or other corticosteroids, the patient's monocytes are not suppressed, their function is not suppressed, they are reprogrammed toward innate immunity function, innate immunity-related function. So can this be shown in vivo? Yes, it can. So this is a very interesting experiment done in rabbits. So rabbits were exposed by intratracheal administration of endotoxin. And then the animals were sacrificed, and using immunofluorescence and other molecular tools, the researchers were looking at NF-kappa B activation. So the green color here show you the huge amount of NF-kappa B that is present in the cytosol. And if you look in the blue, which is the nucleus, you can see that there are also green color there, highlighting that NF-kappa B have migrated to the nucleus. Now, instead of sacrificing the animals, after the endotoxin challenge, are treated with corticosteroids for 10 days. Then they're sacrificed again. The same experiment is done, and one can see that there is no more NF-kappa B at all. So in this animal model, rabbits challenged with endotracheal administration of endotoxin, 10 days of corticosteroids fully inhibited NF-kappa B production and also cleared from the tissue all NF-kappa B that have been already produced, including in the nucleus. So that is a very potent biological activity of corticosteroids that is demonstrated in an animal model. What happens in patients? So here, this is coming from Germany. Again, it was almost 20 years ago. What they did is they had patients with septic shock in the ICU, and they sampled the patients to look at the circulating monocytes. They took the circulating monocytes and they looked ex vivo to the expression of NF-kappa B by Western blot, measuring P50, P65, P50, P50, as one can see here. And this at baseline without receiving hydrocortisone, and before and after ex vivo stimulation by LPS. So before LPS stimulation, the monocytes already express a high level of NF-kappa B, and they continue to express even more after exposure to endotoxin. Now they treated the patient with hydrocortisone for 1 day, and they took again the monocytes from the blood and repeated the analysis ex vivo. And what they found actually is that before LPS exposure, there is a substantial reduction in the amount of NF-kappa B produced, and stimulating the monocyte ex vivo with endotoxin still increase a little bit NF-kappa B, but much less than at baseline. And after 5 days of treatment with hydrocortisone, the patients were again sampled, and look at this. There is no more NF-kappa B expressed by monocytes at baseline or after stimulation by LPS, again demonstrating in patients in the ICU that a 5-day treatment with hydrocortisone, 200 milligrams per day, results in a profound and sustained inhibition of NF-kappa B pathway. So, when talking about corticosteroids, we have seen there are genomic, non-genomic effects, there are different molecules, and also we need to consider the mineralocorticoid activity. So again, hydrocortisone is a reference drug, and one can see that most of the synthetic corticosteroids are more powerful in terms of glucocorticoid activity, including fludrocortisone, 10 times more powerful in terms of glucocorticoid activity than hydrocortisone. When looking at the mineralocorticoid activity, none of the synthetic corticosteroids have mineralocorticoid activity, or little, for prednisone, prednisolone, and methylprednisolone. And of course, fludrocortisone has a much higher mineralocorticoid activity than hydrocortisone. And there is no known so far non-genomic effect of fludrocortisone. So all these has to be taken into consideration. And it is very interesting to think about the role of mineralocorticoid receptor in the setting of sepsis and acute inflammation. This is a very beautiful work done 10 years ago. What they were looking at whether the mineralocorticoid activity and an effect on blood pressure is only related to renal sodium reabsorption. So they built an animal model that expressed mineralocorticoid everywhere except in the kidney. So you remove any sodium retention triggered by mineralocorticoid, because there is no more expression of the MR at that level. And one can see, for example, here looking at systolic blood pressure, one can see that the effect of the mineralocorticoid is independent of the mineralocorticoid receptor in the kidney and is not related to renal retention. So it is related to other mechanisms, and as shown, for example, by producing vasoconstriction by potassium chloride, phenylephrine, or by other vasoconstructive agents. So what we did in our lab is we were looking at mineralocorticoid receptor elsewhere than in the kidney, and in particular in the vessels and in the smooth muscle of the vessel. So what we did here, we used aldosterone as a mineralocorticoid drug, and we looked ex vivo. First, we shown in vivo that the systolic arterial pressure, this is the control patients, the black circle, and when you give endotoxin, as you know, the response to phenylephrine is impaired by endotoxin in the white circle here. So shift to the down, to the right, and to the bottom, indicating an impairment in the alpha agonist, alpha receptor complex activation. So we looked, and aldosterone is, improving, not normalizing, but improving significantly systolic arterial pressure following the endotoxin challenge. And now we took the aortic rings and the mesenteric artery rings, and we looked at the contractility of these arterial rings. So again, the control contractility here, that's a normal condition when the animals have received endotoxin, major vasodilation, reduction in the capability to contract in response to phenylephrine, and aldosterone is partly reversing this. This also looking at now in the D panel, we are looking at the expression of the receptors, the alpha-1 receptor, A, B subtypes, the endotoxin receptor, the angiotensin II receptor. So LPS in black bars here, downregulated all types of alpha-1 receptor when aldosterone is added after the endotoxin challenge. In the gray bars, one can see the restoration of expression of all subtype of alpha-1 receptor, highlighting that mineralocorticoids are able to counteract the endotoxin associated downregulation of the alpha receptors. So very interestingly, we demonstrated in that experiment that vascular mineralocorticoid receptor expression is markedly decreased, both at the early and late phase of the endotoxin shock, as compared to the GR receptor, to the glucocorticoid receptor, again in the smooth muscle. So in white bars is the GR, in black bars is the MR. And so one can see that the MR, not the GR, is downregulated following endotoxin, with upregulation associated with exogenous aldosterone administration. And this is true for the mRNA assessment or the protein itself measurements. Now let's move to humans. So this is again a landmark paper by Bakat and colleagues in 1996, where they were looking in healthy volunteers challenged with endotoxin. So basically, they looked at the percentage of contractility in response to norepinephrine of the veins. And so before giving hydrocortisone, one can see here that endotoxin administration, gray bar compared to the orange bar, is associated again, unsurprisingly, with a marked depression in the contractile response to norepinephrine. The volunteers then received 50 milligrams of hydrocortisone. The same experiment was redone, and one can see again a nice normalization of a contractile response to norepinephrine. Moving to patients, some time ago, we were looking at the pressure response to incremental dose of norepinephrine in ICU-treated septic shock patients. And we look at this in relation with the normal production of cortisol, of the endogenous cortisol. And so what we figure out here is that the patients were not able to produce normally endogenous corticosteroids, had a marked depression in the contractile response to norepinephrine compared to those who have a normal endogenous production of cortisol. When we give 50 milligram IV bolus to these patients and repeated the norepinephrine incremental dose response curve, one can see that hydrocortisone fully normalized the pressure contractile response to incremental dose of norepinephrine. very similar to what is found in preclinical models, very similar to what was found in healthy volunteers challenged by endotoxin. So that is a robust pharmacological effect of hydrocortisone in sepsis. Let's now discuss the clinical evidence. So in 2002, in JAMA, we published the first French multicenter trial that established that in septic shock patients, in patients not able to respond appropriately to the synaptin test, we found a remarkable improvement in survival in patients receiving hydrocortisone plus fludrocortisone compared to placebo in red curve. In patients with adequate endogenous production of cortisol, we couldn't find any effects. As you know, the European Corticus study published in the New England Medicine in 2008. As you know, I was the co-PI of that study. The study globally didn't find any survival benefit from hydrocortisone in patients with septic shock. But what many people has missed in the paper is that we did look at the group of patients included in Corticus that would have been eligible, had the same criteria than the JAMA 2002 study. So there were, as one can see here, a total of 173 patients out of 300, that is in our studies, receiving corticosteroids. That is a postdoc of Corticus study. We had 126 patients that made the French criteria. And what we found is exactly replicating what was found in the JAMA 2002 paper. That is a marked survival benefit from hydrocortisone in those patients not adequately producing endogenous cortisol, and no effect or no evidence of an effect in those who are able to produce adequately endogenous cortisol. Since these all studies, we have landmark recent study in septic shock patients, the approach trial showing a net survival benefit by the combination of hydrocortisone plus fludrocortisone. We all know the story of the effects of corticosteroids in severe COVID-19, where the effects are proportionally greater with the severity of illness in COVID-19 patients. This is from the recovery platform. Even more recently, we have the severe CAP study, the CAP code study that have shown a very nice and significant improvement in mortality in patients receiving hydrocortisone while admitted in the ICU for CAP without shock. And even more recently in Kenya, we had that very beautiful study showing that again in more than 2,000 patients in Kenya with severe CAP, corticosteroid had a survival, significant and major survival benefit. So I think over time, and even more recently, major clinical pivotal studies have highlighted high probability of survival benefit from corticosteroids in patients with sepsis or severe community-acquired pneumonia. This was recently summarized in an update of a Cochrane systematic review that has more than 87 studies now in. Don't look at the row. All these studies are providing data for 28-day mortality. And one can see here a very clear effect of reducing the risk of death at 28 months by the use of corticosteroids in patients with sepsis, either children or adults, and look at the p-value, so the effect is really substantial. So now that we may be convinced that corticosteroids may play a role in patients with sepsis, let's understand how to give them. So first, should we give them as boluses or as a continuous infusion? Looking at all available data in the literature, in the Cochrane review, one can see, looking at the tests for subgroup difference, that there is no evidence that giving treatment as bolus is superior or inferior to giving it as a continuous infusion. So choose the way you are best familiar with to give them bolus or continuous. With regard of how to terminate the treatment, should we taper off or not? Again, no evidence that makes a difference. So do what you used to do in practice. Regarding now the dose, and that is very interesting. We were looking at the cumulated dose of corticosteroids expressed as equivalent of hydrocortisone in milligram, and we did what we call a meta-regression. And so one can see that there is a significant relationship suggesting that the lower the dose, the more survival benefit from corticosteroids, with likely a dose around 150 milligram per day to be of interest. Be aware that here we're talking about the cumulated dose. So, for example, if you receive 200 milligrams for 7 days, the cumulative dose is 1 gram and 400 milligrams. So the lower that cumulated dose, the higher the survival benefit. And in addition, the longer the duration, also the higher the risk of the chance of survival. So that means that it is the dose and duration should go together. If you use high dose, like 200 milligram of more, you should not treat for more than 5 days. If you use less dose, let's say 150 milligram per day, then you better treat for 7 to 10 days rather than for 5 days. What about fluorocortisone? Again, a decade ago, we already published that fluorocortisone given orally is very rapidly absorbed and with a long half-life in plasma. More recently, our colleagues from the ANSI group repeated this and also tested different doses of fluorocortisone and demonstrating again that the drug given orally is well absorbed. And there was no significant difference between the different doses, suggesting that 50 milligram is enough. And indeed, regardless the outcome they were looking at, there was no significant difference across the different doses, again, suggesting that 50 mics of fluorocortisone is enough. This is our study called COITS that was published in JAMA in 2010. In that study, we were initially looking at the role of intensive insulin therapy to control blood sugar in patients treated with corticosteroids. And because there were no consensus about the use of fluorocortisone, to avoid too much of heterogeneity, we decided to have a 2x2 factorial design and also to look at fluorocortisone versus standard of care. So, of course, the study was not powered for that second evaluation. And what we found is an absolute minus 3% difference in mortality at hospital discharge in favor of the combination of hydrocortisone plus fluorocortisone versus hydrocortisone alone. And very recently, our colleagues in the US, using emulated trial within a large US data set, where they're including all patients with septic shock treated by norepinephrine, and they looked at difference in outcome, whether they receive fluorocortisone on top of hydrocortisone or whether they receive hydrocortisone alone. And so what can see here from that study is that they found a survival benefit with an absolute difference in mortality of minus 3%. So now let's move to rapidly discuss who should we treat? Everyone? Likely not. Again, using all evidence on the Cochrane based on the Cochrane review, one can see here that test for subgroup difference is significant, suggesting that different subgroups respond differently to the corticosteroid treatment. And in fact, one can see that patients who don't have, who have uncomplicated sepsis, these patients do not seem to draw survival benefit as compared to patients with septic shock, patients who have sepsis and ARDS, patients who have sepsis related to community-acquired pneumonia, or patients who have sepsis related to COVID-19. We also try to look whether the baseline severity of illness may play a role, and it did not play a role. So here we assessed, we did the meta-regression using the mortality in the control arm as a reference of severity of illness. And one can see that there is absolutely no evidence that response to corticosteroids varied according to baseline risk of death. So the challenge is to treating only those who may benefit. That is the challenge of precision medicine. We know now that almost 6 out of 10 patients who died, they have immune suppression rather than hyperinflammation. And we also know that 3 out of 10 of these dead patients have glucocorticoid resistance. So intuitively, patients who may respond to corticosteroids are patients who have an hyperinflammation and patients who don't have glucocorticoid resistance. And with that, in that group of patients, we can assume that the benefits on organ function, survival, and cost will by far overcome any risk about metabolic, neurologic, or secondary infections, complications. With Romain Piracchio in San Francisco, we looked at using a machine learning technique and building an intelligent algorithm. And to make the story short, in that study published in JAMA group a couple of years ago, what we demonstrated, looking here at the net benefit of treatment, and in the x-axis, is the number that you wish to treat to get that net benefit. And so what is important to look is at this point, which is the point where you get more patient with harm than patient with benefit. So that is all conventional analysis of whether one treat all patients with hydrocortisone in black, or whether one treat patients based on SAPS-2 at baseline in gray, or whether one treat all patients with hydrocortisone and fludrocortisone. So one can see that there is a benefit, but you need to get many patients, and for many cases scenario here, one can see that it's not very convincing in terms of a patient we wish to treat to get benefit, not harm. Now, if we selected the patients based on an intelligent algorithm that we have defined, look at this, we were able to identify the highly responsive subgroup of patients. So that is, we are continuing to work on this. Other aspect we are looking at as other groups is doing pharmacogenomic studies. So from the approach trial, we get access to whole genome sequencing, and we were able to figure out 2 polymorphisms in 2 important genes. The genes coding for NF-kappa B, in particular the promoter region of the genes, and the genes coding for GLCCL1, which is a major regulator of the glucocorticoid receptor function. And what we found that the number of patients who have polymorphisms in these genes, and that a substantial number of patients, about 1 out of 5 patients in the cohort, has both polymorphism, the polymorphisms in the 2 genes. And one can see here in the top right panel that this group of patients are very likely to die, very sick patients. And when you treat them with corticosteroids, that you get a very important survival improvement. And this is very clinically relevant because NF-kappa B polymorphism is associated with a major production of NF-kappa B, so very high inflammation. And the polymorphism in GLCCL1 is associated with reduced function of a glucocorticoid receptor. So these patients produce a lot of inflammation and cannot counteract the inflammation endogenously. So treating them allow to overcome this and save life. So we are also, as others, looking at transcriptomic signatures using combining artificial intelligence and the molecular biology. We identified a set of 14 genes that were highly associated with response to corticosteroids. I don't have time to elaborate on this, but we'll be happy to answer any questions. And likewise, we are doing metabolomics. I've identified a number of very interesting metabolites, in particular involved in lipids and fatty acids metabolism and in the beta oxidation chain. And these may be very important metabolite to be target in selecting in the future patients who may benefit from corticosteroids. So to end with my own practice right now. So I'm in my ICU. We have received these night 2 patients with severe septic shock. 2 men, one 20 years old, the other one is 74-year-old. They're all multiple organ failure. What we are just treating them with hydrocortisone, 50 milligram Q6. We started the treatment as soon as norepinephrine was demonstrated to be needed, that we were increasing the doses of norepinephrine very rapidly. So within the first 6 hours, we started the patients on hydrocortisone, 50 milligram in bolus every 6 hours, and we added fludrocortisone on top in the NG tube. We are going to treat these 2 patients for 7 days. And we're not going to taper the treatment after 7 days. We'll stop it right away. And these patients, indeed, both of them have septic shock. Both of them have ARDS, very sick patients. One out of them has sepsis related to CAP. The other one is sepsis related to hospital-acquired pneumonia. And it happens, hopefully, now very occasionally that we still get some patients with COVID-19, in particular immune suppression patients. And in these patients, we continue to give them corticosteroids, hydrocortisone plus fludrocortisone. So this is my conclusion. And I also would like to mention that we are using the synactin test not to start the treatment, but to help deciding stopping the treatment prior to 7 days in case a patient is not clinically responding and the patient has actually a normal response to the synactin test. So thank you so much, and let me take the opportunity to invite you to join us for the International Sepsis Lecture. The next one of this month, in March 24, will be given by Bervin Singer, that will summarize how we should assess organ dysfunction in sepsis now. And the next month, Bram Rochberg from Canada will update all of us with the newest, latest release of the Surviving Sepsis Campaign guidelines. Thank you very much for your attention.
Professor Anansar, that was wonderful listening to you talking on steroids. I think they can be nothing better than that. And we have a very large audience. So I request the audience, please type your questions. I will be happy to answer. So far, there's nothing. Maybe I can just put up some points which will be of interest to everybody. Sir, we talked about hydrocortisone and dexamethasone and methylprednisolone. And one difference is the duration of action, which you showed is related to the structure. Then you talked about their water retaining properties, and then you talked about genomic and extragenomic effects. So, sir, for lung conditions, septic shock, we use hydrocortisone probably because it acts fast, it's shorter acting, right? But for lung condition, there's no consensus, right? Pneumonia, we are giving hydrocortisone. For ARDS now, you can give anything, it seems, DEXA or, So how do we explain this? Do we have an understanding of what goes on in the lungs in terms of the different preparations of steroids?
Yeah, this I haven't discussed that point in the pharmacological section, but what we know indeed is that the corticosteroid distribution varies according with the organs and the type of molecules. For example, we know that methylprednisolone is by far the corticosteroids that concentrate in the lung more. So if you're targeting lung inflammation, you can be sure that methylprednisolone concentration achieved in the lung are going to be higher than hydrocortisone or dexamethasone with the same equivalent dose. So on the other side, if you look at the CNS, in particular in condition with meningitis and inflammation, we know that dexamethasone is more likely or will penetrate, will cross the barrier faster than hydrocortisone methylprednisolone. So this is another aspect indeed to consider when treating the patient. So again, I think that it is reasonable to say that if there is huge lung inflammation, like in severe ARDS, one may wish to prefer methylprednisolone to hydrocortisone. Or one may also prefer dexamethasone to methylprednisolone. The reason why is even if much less concentration of dexamethasone will be achieved in the lung tissue compared to methylprednisolone, the glucocorticoid activity of dexamethasone is 5 times higher than the one of methylprednisolone. So even so, you get much less drug in the lung, you will get a stronger glucocorticoid activity and anti-inflammatory effect.
Thank you for
I hope I answered your question.
Thank you, sir. Sir, then you mentioned about the genomic and extragenomic effects. So clinically, how do they transcribe the genomic and the extragenomic effects?
Yeah, for sure. So the non-genomic effects are something that we are more and more learning about the past decade. So initially, it was thought that the non-genomic effect were more likely to be involved in regulatory processes. For example, they were first described in the brain and being involved in the negative feedback loop that cortisol exerts on the hypothalamus and the pituitary gland. More recently, it was there were several nice and elegant studies in the rheumatoid fields in chronic arthritis, nicely demonstrating that actually the non-genomic effects also occurred in inflammation, in inflamed sites, in inflamed tissues. And that non-genomic effect is in contrast to the genomic effects that, as I shown, at sometimes achieve a plateau because of a saturation of the glucocorticoid receptor. So that is a phenomenon that is not seen with the non-genomic effect because there is no saturation effect. So increasing dose will further increase the non-genomic anti-inflammatory effect. And so this is, as I mentioned, it may be more relevant for the rheumatoid field because in critical illness, in sepsis or ARDS, we are no more trying to use pulse steroids therapy or very high dose. And so in that context, it may be that the non-genomic effects are much less important than in the rheumatoid field.
Thank you, sir. So one question has come from the audience. Dose of methylprednisolone infusion is based on actual weight or predicted weight?
So, sorry, can you say it again?
Yes, sir. So one question from the audience. Dose of methylprednisolone, sir, is it based on actual body weight or predicted body weight?
Yes, we should always. This is true for methylprednisolone, dexamethasone, hydrocortisone. We have the bad habit talking about non-weight related dose, and that is an error. because we know that we have the giving 200 milligram of hydrocortisone or 1 gram of methylprednisolone is not the same to someone whose weight is 70 kilo versus 100 kilos. So yes, this is true for methylprednisolone, but also for hydrocortisone and dexamethasone. We should really do just like our PED colleagues who always talk about those related to weight.
Thank you for the answer. So then you talked about use of steroids in ARDS pneumonia. You told us the dose. You told us do not taper. I mean, makes no difference. But at what point is there a cutoff? You know, there's an early phase, there's a late phase in ARDS. Similarly, pneumonia, if you go too late, might be a problem.
Yeah, for ARDS, we know since 2 decades now that we should not give them too late. We know that the later we introduce them, the more likely we get a benefit. And even if we give them after 2 weeks, we may even harm the patient. So in ARDS patients, it is important to think about corticosteroids within 96 hours. In between, 36 hours to 96 hours. There's no reason to use them earlier than 36 hours. So first, let's start by the common management of ARDS patients, including prone position. And if the patient is not improving, then it is worth considering at 36 hours, between 36 and 96 hours to introduce corticosteroids and avoid giving them later on and never giving them after 2 weeks.
Thank you for the answer, sir. So then moving on to blood pressure, steroids are recommended after moderate doses of vasopressors in surviving sepsis guideline, and we have been giving for a long time. So what exactly is the mechanism, sir, here of steroids acting to improve the blood pressure?
Sure, as I have mentioned, the mechanism is more likely to be independent of sodium retention. It's really a mechanism related to counteracting the downregulation of the alpha-1 receptors. So sepsis and the toxin bacteria induce downregulation of expression of alpha-1 receptor. So if you have much less receptor for the agonist, then you get hypotension, vasodilation, poor responsiveness to exogenous catecholamine. When you give corticosteroids, what happened is you have an upregulation of these alpha-1 receptor. So then you get more alpha receptor available for the agonist. And this is a reason why you rapidly need much less level of alpha agonists of noradrenaline, and also that you can stop them earlier. So that is the main mechanism of action.
Thank you for the answer, sir. So then moving on to a very, controversial area, corticosteroid, critical illness related corticosteroid insufficiency. The classic concept is if the patient's blood pressure is not improving, everything else is ruled out, you give some steroids and he should respond. So where are we with this concept now, sir? Because it is kind of very confusing now to everybody.
Yeah, sure. I think it's a very far to be completely understood. So there is no doubt that the endogenous cortisol system is not playing well its role in some patients to cope with exaggerated inflammation. What is unclear is how we can recognize this, and we know all the pitfalls associated with the use of synactin tests. We know that cortisol measurement in plasma is also limited because many of these patients have low albumin levels, so it's very hard to interpret total cortisol levels. If you use the simulation test with synactin, then you do not more care about the levels because you are looking at the increments. So it is not likely that synactin modified the concentration of albumin or CBG. So But even having said that, again, it is unclear what is the cutoff for interpreting a normal response to the synactin test. And all this is still a matter of discussion. But in our practice, there is no test that must to stand alone. We are thinking we have many different variables and data that we get at the patient's bedside, and we as physicians have to integrate and incorporate all this information. So, for example, in our practice, we continue to perform the synactin test in patients with septic shock, not to start the corticosteroids. So we do the test, we start the corticosteroids, we reevaluate the patients twice a day. And if after 2 days, the patient still worsen or there is no improvement in the cardiovascular system or in the lung function, and simultaneously, the analysis of the production of endogenous cortisol showed that the patient is able to produce as much cortisol as needed, then we think that the risk to benefit balance of continuing the steroids is not fair enough, and we stop them prematurely. So I think this issue of CIRSE, of corticosteroids insufficiency related, critical illness related corticosteroid insufficiency, is a concept that can be used, that can be operationalized by using the synactin test, as it was recommended by the task force, pending we get more interesting diagnostic test, and you use it in your clinical decision by integrating that information with other information.
Thank you, sir. So then one question on viral pneumonias. So in COVID, it has shown to be beneficial. In influenza, it is not beneficial. And viral pneumonias are important cause of pneumonias coming to the ICU. Now we know that we have PCR. PCR is being used more and more, and viral pneumonia is a big problem. So, sir, do you think in other pneumonias, because viral pneumonias have varied etiologies, right? Influenza is important and COVID is definitely there, but there's so many etiologies. Do you think there's a role for steroids for other viral pneumonias?
I think that at least it should be investigated, because you know what matters. Corticosteroids, they don't care about the bug. What is important is what is the mechanism of a tissue damage. If the mechanism of a tissue damage is inflammation, then it is quite obvious that corticosteroids will have an effect, a positive effect. So that is a question. And the problem is we know that the immune response to virus in the lung differs fairly from one virus to another. We have seen in COVID-19, severe COVID-19, that we may get patients with important neutrophil activation. And that might be at least one reason why corticosteroids may work in this group of patients. But if the lung shows more hemorrhage than immune cells infiltration, that I can't see how corticosteroids may be helpful. So I think that is very important to when thinking about virus pneumonia, viral pneumonia, they are not all the same. And we need to select those patients in whom we can have a high confidence that the patient has lung inflammation, not lung hemorrhage. And that is the main issue to decide.
Thank you very much, sir, for the answer. So then Dr. David Oliveira asks, so which steroid do you recommend for ARDS?
Yeah, I think for ARDS, without shock, not associated with shock, I would say that dexamethasone might be the most easier drug to use because of a long half-life, because also of a possibility of transitioning to oral route when the patient's improved, as compared to methylprednisolone, for example. But it's fair enough to use methylprednisolone. But my preference is to use dexamethasone for the reason I said.
Thank you so much, Dr. Anansar. Final question is about the balance between side effects and the actual use. At some point it leads to immunosuppression, can lead to side effects. So how do we balance this, or where can we be wary of steroids leading to immunosuppression, secondary infection, secondary hits?
Yeah, my own belief, based on all the literature I have and my own experience, is again, the way we're using corticosteroids in the ICU are definitely not immune suppressive drugs. They're more reprogramming the cells. Again, there is strong evidence for that than inducing immune suppression, again, at the dose that we are using them in the ICU.
Thank you very much, Anansar. You answered very nicely. It was very wonderful, the talk and all the questions, the doubts for everybody. I think the discussion was very useful to everybody apart from the lecture, because these are very practical questions, and steroids are an enigma and very controversial area. And new evidence, new news guidelines keep coming up all the time. So really, thank you, sir, for that talk. It was wonderful. Good night, sir. Thank you very much.
Thank you very much. Bye-bye.
Bye-bye, sir. I thank the audience for joining in. I hope they had a good learning session, and I thank everybody. Good night. Goodbye.
Ouais.